Okay, Bismillahirrahmanirrahim. Good morning and Assalamu alaikum. I am Dr. Johar Ali from the lecture hall number 1. And as you people know that things are changing rapidly in our country because of this coronavirus, and all management systems are going on uh, online, starting from e-governance to e-learning. And this is one of the educational and teaching strategies, what we call it e-learning. And there are almost 25 universities across the world. They are actively pursuing this strategy for teaching and learning purposes. And these are known as virtual universities. So we are also trying to do that. And this is one example today. Let's see what is the feedback of this lecture online. So students, I hope you are all okay back at home with all your friends and families. You must especially take care of your grandparents, your parents, your brothers and sisters, your friends and your neighbors. And inshallah, we will fight this menace of coronavirus and we will come successful. We were discussing undescended testis the other day, and I almost concluded without these slides. Today I'm going to show you a few slides as well so that it will be completed. There are different types of anomalies encountered in testicular descent, and you start with the absence of testes. At times, testis is congenitally absent. During intrauterine life, there is ischemia of the testes, and that is not there. And apart from that, there are different varieties of testicular diseases, and they are undescended testes, retractile testes, and ectopic testes. So undescended testis is basically it's a normal path. The testis follows but does not reach to the scrotum. And ectopic testis is the testis that does not follow the normal path of descent. While retractile testis is basically a normal testis, but due to hyperreflexic steering muscle, it's hidden into the superficial inguinal canal, or it is located near superficial inguinal ring. So embryology, we have already discussed. The genital ridge is there, intermediate plate mesoderm, and is derived from yolk sac. Leydig cells and Sertoli cells are there, and the vast difference formed by mesonephric death. This is embryology of the testes. And what happens during intrauterine life, it starts descending at 8 weeks of gestation. And it reaches to the deep inguinal ring by 3rd month and lies dormant up to 6 months at the level of deep inguinal ring. And it traverses inguinal canal during 7th month of pregnancy. And it reaches to superficial ring by 8th month. And by 9th month, it reaches at the bottom of the scrotum. Now, what are the forces that contribute to the descendancy of the testes? Number 1, transabdominal phase and transinguinal phase. Secondly, so in transabdominal phase of testicular descent, there is mainly increased intra-abdominal pressure and the pull of gubernaculum. As I have told you before, gubernaculum is a tissue that is generally avascular or non-vascular, that is attached to the genital ridge in the lower pole of the testis, the later testis, and under the influence of certain hormones and because of contractility of that caverniculum, it pulls the testes down into the scrotum. And intra-abdominal pressure also facilitates its descent. So transinguinal phase is basically a combination of mechanical factors and hormonal factors, and the prime hormone responsible for its descent is testosterone. That's how testis descends into the scrotum. You can see here is the testes, and this highlighted dark gray vein is a caverniculum. It pulls the testes down into the scrotum. And meanwhile, there is this is the processus vaginalis, which becomes later on tunica vaginalis, and if it remains persistent, there is what we call it hydrocele. So this processus vaginalis later on gets obliterated, and this is the tunica vaginalis, and this is the testis. What are the clinical features of an undescended testis? So absence of testis in the scrotum, once if you see the child in outpatient department, usually they are brought by their parents and they are anxious. And when you examine this patient, you will see hemiscrotum empty. And if there is testis and patient presented late, it is generally having hypoplastic hemiscrotum. The testis may or may not be palpable along the path of descent, and 70% of undescended testes are palpable, and only 30% are non-palpable. This is the course of testicular descent. This is intra-abdominal testis. This is the location of intra-abdominal testis, and this is a canalicular phase of intra-abdominal testis, and now this is the testis in the inguinal or prescrotal and pubic space. So this is basically a normal path of descent, and it can be arrested in any part of its normal path of the normal pathway. And this is highlighted superficial inguinal pouch, and this is the testis, and this is the blood supply and vas in this spermatic cord. So what is the pathophysiology of undescended testis? What happens when the testis is not placed, it's not brought down to its normal location? Structural and functional changes occur. The testis has got different cells, and they are producing different hormones and sperms. So hormones are there produced by Sertoli cells and Leydig cells. There is testosterone and estrogen, and germ cells, they produce sperms. So what happens if the testis is not and it's a proper location and is subjected to hostile environment? So there are some complications. If you will recall my previous lecture, I have told you a formula for that, and that is testis. So there's more information here. So what will happen if the testis is not there in the right place? What will happen? Patient will go infertile. This is usually associated with inguinal hernias, is more prone to torsion of the testes. Patient can develop seminoma of the testes, and the testes fixed in the inguinal canal or superficial inguinal ring, it will become a fixed sort of thing. So what will happen? It will be more prone to trauma. And obviously it has got psychological impact on your patient. So what investigations you do basically, if palpable, no investigation is needed. It is superficial inguinal ring and in the inguinal canal. If the testis is there, there is no need to go for any kind of investigation. It is just there. And if it is unilateral and impalpable, no investigation needed, but ultrasound is done by many people. If it is bilateral and it's impalpable, so you have to rule out intersex if genitalia look abnormal. So how you are going to manage patients with undescended testes? No surgical treatment is required till the child is 1 year of age, unless there is associated complications like torsion or inguinal hernias. So you have to wait for 1 year. If testis is not descended to in its proper place, you have to go for surgery. And if the testis is palpable and it's unilateral, you have to go for Orchidopexy. And if it is bilateral and palpable testis, so you have to do bilateral Orchidopexy in the same sitting. So impalpable testes are 30% of all UDTs, 45% are intra-abdominal, and 20% are canalicular, 35% are vanishing testes. Vanishing testes is basically a testis that is either torted or due to any other reason. If there is no blood supply to the testis during its intra-abdominal developmental phase, the testis is ischemic and it is virtually atrophic and it's vanished, it is gone. So this is known as a vanishing testis. Anarchia is another condition. So how you fix the issue? You can do it by open surgical methods and laparoscopic methods. So in laparoscopic method, it is diagnostic as well as therapeutic. So what you have to do is you have to do diagnostic laparoscopy and you will assess the anatomy of the testis. If the blind ending vessels are there, the vessels are not going to vascularize the testes. You have to terminate the procedure because you cannot do much because the testis is not being supplied by any vessel. So if the vessels are exiting from during laparoscopy, you notice that the vessels, that is the gonadal vessels supplying the testes, are exiting from internal ring. What you have to do is either, if you have confirmed that, if you don't have the expertise to do laparoscopic orchidopexy, you can open the inguinal canal and do orchidopexy. So for intra-abdominal testes, because it needs a longer pedicle or blood supply along with the testes. So in one stage, if you try to bring it down to the base of the scrotum, it's not possible. For that, you have to do another procedure, laparoscopic procedure, what we call it, Fowler-Stephan procedure. And technical details are there, but the whole idea is you have to clip the vessels supplying the testes and do not do orchidopexy in that sitting. So you have to wait for a few months and then again go. Meanwhile, it will take its blood supply from the artery to the vas and surrounding other vessels. So you can bring down a viable, testis into the scrotum. So in inguinal conventional exploration, you have to look for the testes and you have to look for the vessels and vas. And if the canal is empty, you have to open the deep inguinal ring and you have to explore retroperitoneum and try to see up to the lower pole of the kidney. These are the steps of orchidopexy. There is the open orchidopexy. You have to make a groin incision. You have to divide the gubernaculum. You make sure that you have done herniotomy, divide pins, holding the vessels to the lateral abdominal wall, and place the testis in the dartus pouch, and what we call it Aberdeen's operation. These are the stages of orchidopexy, and you have to make an inguinal incision here. You can see incision, the gubernaculum, you mobilized it, and sorry, and this is what Darda's pouch is. You have to put your left index finger through the inguinal canal into the anus scrotum and just make a horizontal incision over the scrotum. Make a pouch for the paxive purposes and bring testis through a hole in the dartus muscle and place it between the scrotal skin and the dartus muscle. So it will act as, a retaining sort of thing. So it will not spring back to the towards the deep inguinal ring. So Stephen Fowler operation or Fowler-Stephen operation is basically a laparoscopic operation. So you have to ligate artery and vessels to the testis intra-abdominally if the pedicle is quite short, and revisit after say a few months. Collaterals will develop, and then you will do orchidopexy. So this is you can see in this picture. This is the conventional orchidopexy by open surgical approach, and in contrast, you have to do laparoscopic. So when you will free the spermatic cord from other tissues laparoscopically, and you bypass the curve of indirect canal, so you will straight away come through superficial inguinal ring. So this is laparoscopic orchidopexy. Right. So this was all about our remaining part of undescended testis. You have got some idea about undescended testis, though we have discussed in detail in previous lecture. And if you were in front of me, I would have asked questions from you. So for today, I think I must say goodbye now. So we'll come back. I will ask questions from you. Allah Hafiz. Thank you very much for your patience.